which which aims to temporarily correct myopia as well as slow down the progression by flattening the central cornea. So the history dates back to 1960s when the first lenses were made with polymethyl methacrylate, but they were discontinued due to the impermeability of oxygen to the cornea. And then in 1970, there was reintroduction of the rigid gas permeable lenses, which improved comfort and safety. And in 1989, Nick Stoyan and his colleague created the first reverse geometry lens with a secondary curve of steeper slope than base curve. And in 1998, Context Inc. got FDA certification for daily wear Ortho K design. And in 2002, FDA approved the first overnight Ortho K lens designed by Paragon Vision Sciences, which included lenses for all ages and up to -6 diopters. So the mechanism of action is basically, as we all know, that there is a relative hyperopia in periphery in myopic eyes, which is more as compared to the emetropes and hypermetropes, and they have a higher peripheral defocus, hyperopic defocus, which occurs 2 years before the onset of myopia. And with the traditional correction of contact lenses and the single vision spectacles that we use, the central part gets the central image is focused at the fovea, but the peripheral part still has the relative hyperopic defocus. And optimal correction, which is also done with the DIMS lenses, is there is the relative hyperopic defocus in the periphery is converted to a relative myopic focus so that the progression doesn't happen. So this in these Ortho K lenses, the central cornea is flattened and it becomes oblate shaped. And the image is focused centrally at the fovea, where there is the juncture between the oblate portion returns to the original curvature, and the peripheral light focuses anterior to the peripheral retina. So there is a relative myopic defocus, and this helps in slowing down the axial length growth. And so it has both a corrective as well as a preventive role. As shown in this image, so it's like just like the DIMS lenses that we had earlier talked about. And so the ideal patients that are there are those who have a myopia between -1 diopter to -5 diopter, and with the rule astigmatism of less than 1.5 diopters, and against the rule astigmatism of less than 0.75 diopters. The mesopic pupil diameter should be less than 6 mm, and those who are intolerant to the daily soft contact lenses that are there, they like those who have allergy to the material, and also like those who have dry eyes are good, they can use these as a better option. And those who are free of ocular diseases like corneal dystrophies, keratoconus, and it is also helpful in pre-myopes and those involved actively in sports, and those who are not willing to wear glasses or contact lenses during daytime, and they want a non-surgical alternative to LASIK, and those who are motivated, and also those who can afford the treatment, initial and also the continuing costs of the therapy. So basically, before the fitting of Ortho K lenses, there has to be a proper cycloplegic refraction, keratometric readings, and corneal topography, tear film analysis, biomicroscopy, horizontal visible iris diameter, and pupillary diameter in photopic, mesopic, and scotopic conditions. After that, based on these data and the subjective refraction, the keratometric reading, and there is an initial shaping lens that is designed, and some companies, they have a particular nomogram and computer design software that helps in calculating the exact power and everything. And there is the criteria for lens selection is based on the base curve, the lens diameter, and initial lens power selection, and lens design and fitting. So basically, the base curve that has to be decided, it has to be flatter than the flattest K, and the alignment curves. The posterior apical radius of the base curve is calculated using this formula that is written. That is 337.5 divided by the flattest K plus the target correction that we want. Suppose if the patient has a myopia of say -4 diopter, then that will be our target correction, which is subtracted by a correction constant, which is usually 0.75 diopters. So that is because of correction factor is an additional amount of flattening that is figured into the base curve to overcome a slight amount of initial rebound that happens when the lens is first removed. And the average lens diameter that is used is 9.8 mm to 11.5 mm. And depending on the keratometry, it has to be changed. The flatter the K value, the bigger the lens diameter. Say, if it is less than 41 diopter, then it has to be 10.6 mm. If it is between 41.25 to 45, it will be 10 mm. If it is more than 45.5 diopters, then it is 9.8 mm. And the initial lens power selection is based on the standard procedure, and the compensation for vortex that is there. The nowadays the lens design is somebody mute. So the lens design and fitting that is there is
ફોન કરશે કે તમે ખોટો લખ્યો નંબર મને બે વખત પૂછ્યું તમે હરખું લખ્યું મેં કીધું હા ભાઈ હરખું જ લખ્યું છે.
So there is some audio that is coming from somebody.
તો હવે 9 તો તમારે 8.75 નો
Dr. Preksha, hello. Can you please mute yourself?
નથી કરી દીધો ને લેન.
Dr. Preksha?
Yeah, please. Just a minute.
So the lens design and fitting is nowadays the lenses are oxygen permeable and they are based on the reverse geometry with 4 to 5 zones. The curves of the Ortho K lenses basically. I think somebody else's audio is also coming. Okay, the curves of the Ortho K lenses are basically divided into functional curves and those curves that are responsible for the stability and alignment. The functional curve includes base curve and reverse curve, and the curves are for alignment are alignment curves and peripheral curves. So this base curve that is there, it flattens the central part of the cornea by applying pressure in the central part. It is flatter than the flattest K, and it pushes the epithelial cells towards the sides. So, and it is modified to match the refractive error of the patient, and it is responsible for zero power at the center. Then there is the reverse curve that is produced to create a space where the tears can come in contact with the cornea. As can be seen over here, there is pooling of dye. So it is steeper than the base curve, and it allows the epithelial cell migration, and it creates a peripheral hyperopia. And depending on how much peripheral hyperopia we want, we can customize the steepness of the reverse curve. Then there is the alignment curve. So basically both the curves, base curve and reverse curve, are responsible for the functional part, and then the alignment curve is there it connects the reverse curve with the peripheral curve, and it is responsible for centration and stability, and there is no pulling of the dye as indicated by the arrows. And the peripheral curve is the outermost curve, which it provides the edge lift and prevents the complete seal off. So it is responsible for a comfortable wear. Now, after the application of Ortho K lenses, we evaluate whether it is ideal fitting, steep fitting, or flat fitting. Ideal fitting lenses should be well centered with a central alignment zone of 3 to 5 mm, and the movement is about 0.5 to 1 mm, and the reverse curve zone that is seen is wide and uniform, and mid peripheral curve is uniform. And then the steep fitting, if the lens is steep fitting, then the It may be well centered or it may be inferiorly displaced with a very less movement of less than 0.5 mm. And in the flat fitting cases, it is usually superior. It may also be inferior, but the central alignment zone will be more than 3 mm with the reduced or absent mid peripheral curve, and it will be highly mobile. The mobility will be more than 2 millimeters. And see, this is the ideal lens fit in which it has a bullseye appearance of the central flat, the mid peripheral rise, the uniform pooling of the dye is seen, followed by the alignment curve, which is flat, and then the peripheral curve, which is showing at the edge as the edge lift. And then if there is a central island, it means that it is a steep Ortho K lens. So, and it can be reversed by flattening the reverse curve by 0.2 mm. It can now there can be different decentrations, like superior decentration, inferior decentration, and lateral decentration. So in the first image that can be seen, there is the superior decentration, which can be corrected by steepening the alignment curves by 0.1 mm. The second one is the inferiorly decentered Ortho K lens, which can be corrected by flattening the alignment curves by 0.1 mm. And the third one is lateral displacement, which can be corrected by increasing the overall lens diameter by 0.4 mm. The morphological changes in the cornea that happen are seen like before orthokeratology treatment. As can be seen in this image, there is uniform thickness of the corneal epithelial cells all over. But after the orthokeratology treatment, the corneal epithelial cells under the base curve of the lens have show a flattened epithelial surface with the heaping up of the epithelial cells, that is the migration of the epithelial cells towards the reverse curve area, and also ovalization of the cells can be seen in the under the reverse curve area, and also followed by flattening in the alignment curves under the alignment curves area. So basically there is a redistribution and remodeling of the anterior corneal tissue, and it's a temporary change, it's a reversible change, which involves the central thinning, and it's mostly epithelial in composition, while the mid peripheral thickening also has a stromal component. So the central thinning happens because of the compression and flattening, that is the push force, the positive force by the base curve that is flatter than the flattest K. And this mid peripheral thickening happens under the reverse zone, which is subjected to the negative force, that is the pull force, and which leads to larger and more oval mid peripheral epithelial cells. And also the hydraulic forces that act on the posterior lens tear film surface, they cause tangential stresses across the epithelial surface, and that's how the surface changes occur. So basically now the early initiation of the Ortho K treatment can lead to a reduction in prevalence of high myopia. But the disadvantage is that it requires a specialized training, equipment, and skills, and also cleaning and disinfection of the lenses and the accessories and its maintenance is of importance, because it reduces the incidence of microbial keratitis. And also with the recent advancements like wound lens and REM lens, Ortho K lenses, they have caused an improvement in the myopia control. But as sir had mentioned in his lecture, in his video on Ortho K, that basically it is mostly involving the corneal surface and it has no effect on the scleral growth. So whether it will be effective in controlling the progression, it is not known. So further investigations are needed to, like, whether it is it is helpful in permanently reducing the risk of myopia onset or not, and also like to whether it is effective in halting the progression. It is I conclude by saying that it is a safe and effective method of controlling myopia in children and it helps by providing excellent vision and improving vision related quality of life, as it has to be worn only at the night, and in the daytime the patient is free of any type of glasses or lenses, and so it is more convenient. And also it is helpful in lowering the prevalence of high myopia in younger children if it is initiated early. So that is what. Thank you. Thank
Great, wonderful slide. And the end.
Thank you, sir.
So if there are any questions we can take. See, orthokeratology as a therapy is not something which has come up recently. Most of us as ophthalmologists know. Only thing is, for myopia control, yes, it has been on the same principle as the myopia defocus lenses work. And at this point of time, I'm not using a lot of orthokeratology because mainly the cost is a very big constraint. And also in kids, little bit, I'm afraid that it may lead to some corneal issues or something. Otherwise, obviously, orthokeratology is not something which has not been standing the test of time. It's quite an old, way of treating myopia, basically to make patients spectacle free. Only for myopia control. At this point of time, we use orthokeratology for myopia control only, if we don't have anything else. Yes, Dr. Kalyan, please tell.
Sir, you just concluded with the sentence which I was about to ask, that when do you choose this modality over other modalities?
Obviously,
Yes, sir.
there are 3-4 things in support, and so whenever we choose a modality, we want to be sure that it is working for most of the times, it is cost effective, and pretty sure that it is not going to lead to a new problem. Why atropine has become the primary therapy is because whatever it is not going to harm the patient. So that is the first basic rule. Second thing is that it is not very expensive also. The problem of atropine, if we have to choose among all the medicines, the problem of atropine is that, the compliance is an issue. With glasses, compliance is not an issue. With orthokeratology, compliance is definitely an issue because they have to wear it at night. But then, if you don't give them glasses, they won't be able to see if they don't use the lens at night. But when you use the lens at night, things are not under your control. So definitely, even if bulk of the orthokeratology people who are practicing orthokeratology say that it is pretty safe and the incidence of keratitis is not there, whenever we talk about Indian population, obviously we are a little bit worried that, there may be a contamination, there may be a problem, and, giving kids a modality of treatment which creates another problem is definitely not what we want. So this is at this point of time, we do not have low level red light therapy. So or otherwise low level red light therapy. So my way of treating the patient would be to start atropine. And if I know that compliance is an issue, I will start with glasses. And then if he is a non-responder to glasses or atropine, I would supplement any one of them and definitely keep the first therapy on. And then if he is not responding to glasses, he will not respond to orthokeratology because the principle is same. So only patients who are responding to glasses would respond to orthokeratology. So the third line of therapy would be low level red light therapy, currently not available. So we have to move on to orthokeratology if it is not working. Orthokeratology along with atropine, not orthokeratology. I will stop atropine and start orthokeratology because in combination also orthokeratology with atropine works much better than orthokeratology alone or atropine alone.
Or maybe
And
atropine
after-
soak lenses,
What?
atropine releasing lenses, ortho K lenses.
See, atropine releasing lenses, then we can reduce the concentration of atropine even further. That is the only advantage of atropine, because we don't need a sustained release. Atropine itself is a long-acting molecule. It is it is like travoprost. It is a long-acting molecule once, and it builds up also. That is also one of the phenomena that atropine has, that it keeps on building up. So maybe if you put it once a day in the beginning, it may not be there. But if you keep on putting atropine daily, the effect lasts for pretty long time.
But I mean, like in prostaglandin analog, they say that even if you miss the drug for a day, it will still have effect. Like that, even if the patient misses atropine, maybe
Yes,
will
yes.
it cushion? It will cushion.
So we did I think Devanshi was a part of that particular study. When we did that study, we actually put the compliance only at 70%. So if you have a 70% compliance, means you are as good as 100%.
Okay, and sir, how much is the actual cost of these Ortho K? I mean, is it based on the diopters
Orthokeratology.
for a 1 year therapy or
So
something?
orthokeratology with SLR lenses is to the doctor, I think it is around 40,000. And I think with toric orthokeratology, and they have a upper limit of -6 diopters. And I think toric also, they have an upper limit of 2 diopters. But if we go with other vendors, the cost comes down to around 30,000 or 25,000. I
And
think
how much
cost
is
is one
to
of
the
the major
patient?
cost to the patient. With I mean, they SLR people say that the MRP is 80,000, and the other companies, yeah, it is expensive. I mean, to the doctor itself, if it is coming to 40,000, and orthokeratology patient is going to stick with you for 1.5 years. So if it comes to the cost, you have to calculate all the follow-ups. Patient will be completely free of cost in India. So they
Yes,
are not going to pay you for any follow-up. If you have charged them, even if
as
you
per
have
the
charged them
cataract
20,000,
surgery.
they are not, you are not going to. Yes, yes. Then it is
But
for
then,
another 1.5 years, it is totally free.
yes, okay, sir. Thank you.
So cost constraint is there with orthokeratology. You can stop sharing the slide, Ramya. So cost constraint is definitely there. There is no doubt about